sound as well. Cecilia Mwanza, good afternoon. I also see we have Chuma B. Chumbwe. Dr. Myangan has just confirmed that the audio is good. Thanks for that. I also see David Chilufya. I can see Dr. Philip Onoya. Dr. Onoya, good afternoon. All right, Dr. DSA, I see you. And, I can see several other colleagues joining in from different parts of the country. You are all welcome to today's ECHO session. We have a very, very interesting session today. And as you have seen from the invite, we are looking at radiological of X-ray, or rather chest X-ray interpretation. So for those of us that have been at this long enough, you will acknowledge that this is the first time we're having a session like this. And so from the start, allow me to just mention that in this session, you will require to actually look at the screen for the most part, because there will be a number of images that will be projected. And so if you're just listening to the audio, you may not benefit the most from participating in this ECHO session. So as much as possible, please sit in a safe space where you have access to a screen and look forward to seeing what will be presented today. So right now in the hub, we have the subject matter expert for the day. He is a radiologist with vast experience in not only chest X-ray interpretation, but as well as other diagnostic modalities in the radiology space. His name is Dr. Nteeni, and he will also be supported by other subject matter experts, Dr. Kondwelani Mateyo, who's a pulmonologist. We also have Dr. Chitalu Chanda, who is an ID physician. Later on, we'll be joined by Dr. Muhamad Mputu, who is also a physician with background in the TB programming. My name is David Singini from the Center for Infectious Diseases Research in Zambia. So without spending much time, allow me to ask our subject matter expert, Dr. Nteeni, to greet the network as we start sharing his presentation.
Good afternoon, colleagues. It's a pleasure to be here, and I look forward to an engaging discourse with all of you. Thank you.
Right. Thank you so much, Dr. Nteeni. And please, colleagues, as we get to the session, just a reminder on the ECHO etiquette that when you are not speaking, please keep your microphone muted. If you have questions or comments while the didactic presentation is going on, please put them in the chat box, and I will make it a point to read them out when time allows. Also to mention that later on in the session, we will have an interactive session with Dr. Nteeni and the other subject matter experts to look at the radiographs and various aspects of the conversation today. So at this point, allow me to hand over to Dr. Nteeni to take us through his presentation.
Thank you so much, David. Once again, thank you for the opportunity for us to have this engagement. And as has been introduced, we are going to look at radiological diagnosis of TB. My name is Dr. Nteeni. So our learning objectives today, the first one is that we're going to outline the steps to reading a chest radiograph or a chest X-ray. And the second one is to describe the common radiological features of TB on chest X-ray. The third is to distinguish TB from other diseases of the chest. Now, as you can see, this is quite a loaded, these are quite loaded objectives. So we decided to split them into two parts. The first session will cover those 3 points there. We'll learn how to assess the quality of a chest X-ray. We'll also talk about the chest anatomy and then we'll do the introduction of how actually we interpret a chest radiograph, the patterns that we need to see there. Then in the next session, we are now going to zoom in on TB in particular, and then we'll finish it off with practical cases and exercises. So without further ado, let me start with this quotation. This is Steve Jobs. He said, "Everything is based on a simple rule. Quality is the best business plan, period." And this is not only true for business people or entrepreneurs, but it's also true for us in the medical field, especially when you come to imaging, as in our field here, radiology. Quality really is the best business, is the best way to go. Without that, really, we will still be in the dark. So, as a way of introduction, we've all been seeing patients, and at one point or the other, we've had to read an X-ray. But what is an X-ray? Basically, this is just a form of energy that is part of what is known as electromagnetic wave spectrum. And what happens is that when an X-ray tube releases those X-rays, they enter through the body, and then the body parts absorb those X-rays at different absorption strengths. And then the transmitted photons or the transmitted energy is now beamed on a receiver, which is able now to transform that information into a picture, which we get as a copy of an X-ray, and we're able to read that X-ray. So there are two ways that, or rather there are multiple ways of getting a chest radiograph, but the two commonest ways that we'll zoom in are what is known as the AP and the PA radiograph. The most common one is the PA, where the light source is behind the patient. So as you can see on this image, just let's put the, so where the rays come from behind, and then they move through the back. No, I wanted the arrow. And then the AP is where the patient faces the X-ray beam, as can be projected there. Yeah. As can be, I hope people can see my arrow there. Okay. So what are the qualities of a good PA radiograph? So the first thing is that all the lung fields will all be seen. Then the scapula will be projected away from the lung fields. Then the medial ends of the clavicle will be equidistant, will be symmetrical and equidistant from the spinous processes. And if there's good, the X-ray is taken in a very good inspiration, you'll be able to visualize the 6th rib and the 9th to 10th rib, which posteriorly. And of course, you'll be able to see the sharply defined costophrenic angles, diaphragm, mediastinum, lung markings, and heart. And we'll go through some of these anatomical landmarks as we proceed. So basically, this is what you want to see when you are presented with a chest radiograph and it is written PA radiograph. How about an AP radiograph? So sometimes we have these patients that are unable to stand, or in fact, children who cannot stand by themselves. So in these patients, we normally take an AP view, and here the beam comes from the front going to the back, and the patients can be either lying back or they could be seated. And because the heart is at a greater distance from the film, hence it will appear more magnified than when you do a PA radiograph. And of note is that the scapula, usually in an AP, they will be seen within the lung fields. So these are some of the things that one has to be aware of as they are reading this AP, so that you do not misdiagnose something. So typically, this X-ray, the lateral chest radiograph is done in conjunction with the PA view, and it basically allows us to view structures that are behind the heart or the diaphragmatic dome, and in fact the hilar, to evaluate the hilar region quite well. In most cases, really, we do not use it as routine, but when you see something wrong on the chest, on a PA or an AP, and you really want to evaluate these structures, the hilar region, the diaphragmatic dome, one can really go for a lateral radiograph so that you can close the case. Okay. So, and as you read an X-ray, you need to take into consideration the technical features. And this is, I cannot emphasize this point enough. We have had misdiagnosis where patients who might have had a normal chest radiograph, but because of the technical matters, you find that this patient is diagnosed to have a pneumothorax or a pneumonia, and sometimes tubes are placed in those patients only to find maybe it's a dry tap. When on X-ray they look like maybe there's a pre-effusion, but when you go back, you realize that actually it's a technical issues that were not correct. So it's important for all of us to learn a few things about these technical features that we need to look at each X-ray as you read. So what are these technical qualities? Number one are the patient details. Make sure you know that X-ray has a name, especially in places where we are not having this digital X-ray, you cannot have the PAC system, and you actually have the physical X-ray. You really want to check the name of this patient so that what you are reading is actually for the correct patient. Then also check the date of the X-ray, and this is also important even as you are following up this patient. As you all know, as you treat the patient, the X-ray features start to disappear. So you need to make sure that the date is there. So that as a patient, as you are following up the patient, you can really treat the patient holistically. Then also, of course, you need that X-ray has to have the where it was done, and in most cases you find that there are those markers that will be there to be either put as a PA or an AP. If it is not put as an AP and P or PA, there are some features that can help you check and you'll be able to see whether this is a PA or an AP radiograph. So the main qualities that you want to look for in determining quality of a chest X-ray are what are the three things: RIP, or rest in peace. And rest in peace is related to death, isn't it? So just as it is related to that, if you miss out these things, you really can bring up a lot of problems. So please, let's look at this thing, these three letters, RIP. So the R stands for rotation. You need to assess if there is any rotation in this X-ray. How do you assess that? Basically, just look at the spinous processes. You look at the clavicular ends, and then you also look at the vertebral bodies and the ribs. The ones that you really want to spend time on are the clavicular ends and the spinous processes. Okay, so what you need to check is the spinous process in the midline. So what you just try to measure the distance, even by eyeballing. What is the distance between the medial end of this clavicle to the spinous process? Compare it to the other side. These distances should be almost the same. Of course, there'll be those small changes, but you should be able to check if there's significant deviation in terms of the distances between the two ends, from the spinous process in the middle to the medial end of the clavicle, as is being demonstrated here. Okay. Then also briefly to get back to PA and AP views, there are these differences that should be noted. In the PA radiograph, the scapula is usually in the periphery, whilst in the AP it will be in the lungs, in the lung fields. The clavicles will project over the lung fields in the PA, and in the AP they'll be above the lung apices. And you can see this is an AP view here, and you can see these are the clavicles. They are right above the apices. Whilst in the PA, you can see that the clavicles are inside the lung fields, and you can see that this is a scapula here. It is within the lung fields. But in the PA radiograph, you can't see it actually. The lung fields are clear of that. And of course, you'll be able to see a gastric bubble. This black thing here we are seeing just below, this is the diaphragm, just below it, you'll be able to see this black, the blackening here. This is a gastric bubble. So that you'll be able to see in a PA, but when a patient is lying down, that fluid really just space, and you will not be able to appreciate it as well. So to just conclude now on rotation, of course, we talked about the fact that you need to measure the distances between the two. And of course, we say that the distance should be equal distance. And the main reason for this, you want to check, you don't want to misdiagnose something that is in the heart. So sometimes if there is a significant rotation, the heart size becomes exaggerated, and one may miscall something there. And of course, you'll be able to see whether there is tracheal deviation if there is a rotation. So here an example of a rotated X-ray. So this is a normal X-ray. On your right there, you have the medial end of the left clavicle. They are just abutting the spine where the spinous processes are, and you can see that the medial end of the right side there is right in the lung fields, and you can see that the distance between this to the spinous process is different is quite significant to the distance from spinous process to the medial end of the left side. So in this case, the rotation is towards the right side. And you can see that where it is rotated here, it's a bit darker than this side. If you are to just compare the two sides of the lung fields, this is a bit whiter, this is more darker. So the rotation is actually on that side where the distance is and where it is more darker. That is where rotation is. Okay, the next thing is what you want to look at is the inspiration. Is this patient, is this X-ray done in good inspiration? That's why when we are doing these X-rays, we ask the patient to hold the cassette well, or to hold the on the sides and then take a good breath. If we have microphones, we even tell the patient to take a good inspiration, and then we take the X-ray. And so when there's good inspiration, you'll be able to count at least 6 anterior ribs, or at least 8 to 10 posterior ribs. How do you count these anterior ribs? So this is what this is the first anterior rib, and this is the second anterior rib, third anterior rib, and fourth, fifth. And you see that the 6th anterior rib just goes and cuts right almost in the center of the right hemidiaphragm there. Okay, or if it was this side, to cut on the left hemidiaphragm there. So you at least are supposed to see at least 6 anterior ribs. Posteriorly, you can also count them. This is the first one, a second, third, fourth. You're supposed to see them up to the 9th, at least 9 anterior ribs. Of course, there will be these variations here and there, but 5 to 6 is okay. 8 to 10 is acceptable. And of course, you tally it with the other clinical issues that are going on in this patient. So this is just to demonstrate to you how, if we do not take a good inspiration X-ray, things can go wrong. Here it is, we have this patient, same patient. On the left, you can see that this X-ray was taken whilst the patient was breathing out in expiration. And so you can see that it looks as though there are issues going on in this X-rays. In the lower zones here, it's a bit hazy. The aorta is looking a bit weird there. It appears a bit more whiter. But when you ask this patient to just take a good inspiration, you see that all that which we were seeing as though there's pathology actually disappears. We are now able to count all the ribs nicely. When in inspiration, we could only manage to count about 3 ribs, 1, 2, 3. But in a good inspiration, we are now able to see that all the 6 ribs that we're supposed to see in a good inspired X-ray come out. So therefore, you need to really check if that X-ray is done in good inspiration. Otherwise, you might miscall and call pneumonias in these patients when in actual fact there is nothing there. So sometimes also we have conditions where the patient has an overexpanded lung. Okay, so that's the importance of also counting. So if you find you're counting the ribs, you count up to 6, 7, 8, you're still counting, and they haven't reached. Therefore, you might want to consider a hyperexpanded chest X-ray in that patient, and there are differentials for that. You might be dealing with a COPD, emphysema, bronchitis, those things. And the other thing that you look for there is you'll be able to see the flattening of the hemidiaphragm. They're supposed to be nicely dome-shaped like that, but as is being described here, they are quite flat. So that signifies that there is just something that is going on that is making this lung be expanded. Emphysema, COPD, those things. Okay, so the P stands for penetration, and the penetration basically is sorry about that.
Sorry, we have someone who's trying to share the screen from that end. So please desist from that. And yeah, thanks.
So penetration really describes the degree to which an X-ray passes through the body. In the normal penetration, at least you're supposed to see 4 lower thoracic vertebrae through the heart. Okay, so we have the heart, which is right there in the center, and the lower 4 thoracic vertebrae should just be seen through the heart. Then also the left hemidiaphragm should be visible at the junction with the spine. So you just follow the left hemidiaphragm there. You'll be able to see it as it sort of meets the spine there. That should be seen in a good penetrated X-ray. And also the last part is the bronchovascular structures should be seen behind the heart. So what are these bronchovascular structures? These are just these linear vascular markings that are found behind the heart there. So we can see these just behind the heart. You can see things that are linear behind that. Those are just vessels, but they're in the lung quite all right, but we can see them through the heart. When it is a badly done X-ray or underexposed X-ray, you'll find that those structures disappear. You will not be able to see them as can be seen here when an X-ray is underexposed. So when the X-ray is underexposed, it means the entire X-ray will be more whiter than what you would expect. Look at this, where the question mark is. You can see the heart here is completely whitened, and behind we cannot see anything going through this heart. And when we follow the left hemidiaphragm there, when we reach somewhere here, we get lost. We are not able to see it nicely kissing the spine there. There's nothing there. And also, of course, we are not able to nicely see the vertebral bodies as we want to see. Compare it with a nicely penetrated X-ray here. Then also, you can have an overexposed X-ray where there will just be an excess of blackness on the film. And in that case, we won't be able to see any lung markings, or if we see them, they'll really be reduced. And of course, by practice, one will be able to tell these kind of features. So generally, if you don't see these lung markings, please do not start thinking this is a pneumothorax. And people have had actually put patients with thinking that it's a pneumothorax, and they put ICDs and all those things, when in fact it's just a technical issues. Okay, so having gone through that, we quickly now go through a basic chest anatomy, which many of us are aware of. So I'll just run through this very quickly. Remember, when we're reading an X-ray, we should be able to tell why something is happening in an X-ray. And of course, that has to do with the anatomy of the chest. So here we are. What are some of the features that we can remind ourselves of? We have the heart shadow, and the heart shadow is made of various borders. We have the right side border and the left sided border. Much of the right side of the border is made superiorly or on top there by the superior vena cava, or SVC, or then next we have the right atrium. So the right atrium and the SVC make up the right side of the heart. When we go to the left side, we have the left ventricle, which makes up much of the border of the heart. And of course, as we go up, we have the left atrial appendage, and then we have the pulmonary trunk, and then we have the aortic arc. That is what will make up the left border of the heart. Of course, we will see the right ventricle right in the center there, but it will not contribute to the borders of the heart unless it is enlarged or there's some issue that is going on whereby the right ventricle moves out of its normal position. Okay, so when we're looking at the heart size, it's good also to measure the heart, what is known as the CTR, or cardiothoracic ratio. This is how we measure it, A over B, where we take the maximal width of that heart, which is A, and then the inner thoracic diameter there, which is B. And in most cases, we should be less than 55% or 0.5. When we see it reaching 0.6, there could be an element of cardiomegaly there. Remember, in children, most children are taken up in AP. So do not follow this rule very strictly in children, because those ones are taken up in AP. If you are to follow that, use 60%. When it's more than 60%, then you can think of a cardiomegaly in children. But generally, in an adult, we are looking at something 50 to 55% as within normal. So like I said, right side at border there, left heart border. Again, to just repeat, SVC there, then right atrium, then left ventricle there, and we have the aortic narco there. Okay. Then other bigger structures that we want to be able to identify on a chest radiograph is the trachea, which is found in the midline. You see it as a very nicely lucent region in the midline there, and in a well-taken X-ray, you actually see it dividing at what is known as the carina there, and you'll be able to see the main bronchi going, the right intermedius there, and the right upper lobe bronchus going, and also the left bronchus there. Okay, then the other thing that you want to look at also on an X-ray is what are known as the hilar region. This is where just these big vascular structures come out from the heart. So you find the pulmonary arteries, pulmonary veins coming out from there. And as they go up and go down, where they intersect there is that angle that they make what is known as the hilar point. So that is the hilar. And you find that the left side will generally be higher than the right side. If you find that the right side is higher than the left side, you might want to look carefully what is causing that pull. And you find that actually it could be some fibrosis there or some pathology going on. That can give you a clue as to what is going on in that patient. Okay, so the other thing you have to look for is what is known as the right paratracheal region. This is just a small region that is close to the trachea there, and it's important, especially for our purpose where we are thinking of TB and its effect on a patient. You find some lymph nodes can start. You may find some lymph nodes in that region, and so this paratracheal stripe becomes unusually large. That gives a clue that there is a paratracheal lymphadenopathy there. And of course, you look at the subcarinal regions. There, usually you see a blackening there. You won't see much happening. But if there are some nodes that have come up there because of TB, you find that becomes prominent, and you'll be able to see it there. And we'll probably show these things as we go into TB proper. And also the other area you want to look at is the aortopulmonary window. So all these regions are potential places where lymph nodes can appear. So this is basically a region where it separates the aortic narco, and the pulmonary vasculature there. That potential space there has lymph nodes, and if there's an infection or even malignancy, you find it's not as nicely black there. It will become whitened there or bulging. That gives you an indication that something wrong is going on in there, and you need to evaluate that patient, tying it with the clinical presentation. And of course, also paravertebral space, some pathology can occur in there, and you need to be aware of those things. Okay, so apart from those structures, we now look at the lobes of the lung. As we all know, the right side is made up of 3 lobes. The left side is made up of 2 lobes in most individuals. Of course, there are variations here and there, but in most patients, most of us, we have 3 lobes and 2 on the right. And as you can see, the right upper lobe, right middle lobe, and the right lower lobe will intersect. You find that if a lesion is somewhere here, you might be tempted to think that this lobe is actually in the right middle lobe. But what you just need to understand is that these lobes intersect. And if you were to really take, for example, a lateral X-ray, there we go. On the right, you have this right upper lobe, right middle lobe, and the right lower lobe there. But when you take the same patient, just do a lateral, you find that actually the right lower lobe extends all the way up here. Okay, right middle lobe is there, and the right, so there will be that intersection. That is why in chest radiograph, we do not really try to call things as lobes. When we see some opacity or some problems in part of the, we call that zones. So we just call it upper zone, middle zone, or lower zone. We do not try to go down to the actual lobe. Of course, there will be cases where you can actually call it a lobe. There are these signs that we can use to call something that is in the chest, and we can, using that sign, we can call it to be in a particular lobe. But generally, we really want to just call it in zones: upper zone, mid zone, and the lower zone, because of these intersections that are there. See on the right side, you see this is how wide the right lobe extends. Okay. So back to the basics. When we're reading the chest radiograph now, there's this acronym that is normally used here. It's called doctors A, B, C, D, E. Okay, so basically the doctors part there is just trying to look at the things that we've already talked about. The DR there is just talking about the fact that you need to look at the patient's name, the date of birth, the biodata of the patient. Then the R is the quality of the chest radiograph. Without these two things, please do not rush to read the X-ray. Go back, ensure that these things are there. You have a good X-ray, and then you are good to go. And as you can see, various people use different acronyms. For my case, I told you that RIP stands for rotation, inspiration, and penetration. But people use it for projection and exposure. It's essentially the same thing. So don't worry about that. It's just RIP, inspiration and penetration, which people can arrange it in different ways, depending on your sources. Okay, then the other thing now, which we want to look at, is what is known as the ABCDE. And this is just to help us as we are reading an X-ray. And people develop different methods, different ways to do it. And you yourself, as you read these X-rays, you're supposed to have your own, develop your own way to do these things. There's no really the hard and fast rule about it. As long as you're systematic, you continue doing the same thing, and that should be no problem at all. So the ABCDE approach there, you start with A, which is the airway. The airway basically just looks at those things that contain air. Okay, that bring in air into the lungs, and the big structure there is a trachea. And the main thing that the question is, what you were trying to ask is, how is the trachea? Is it midline, or has it been pushed, or has it been pulled? That's the only question you really are asking. And if it has been pushed, what is pushing it? Okay, if it's been pulled, what is pulling it? And what in most cases, the things that push the trachea away are large pleural effusion, or the patient has a pneumothorax. If it has been pulled, things such as consolidation with lobar collapse pull the trachea. So those are some of the hints that can help you decipher what is going on in that particular X-ray, and we'll demonstrate this as we do these exercises. Okay. So this is the trachea there, which we already explained, and then we can see it dividing nicely into the carina, into the right and left bronchus at the carina. Okay, and you should be able to see these things. Okay, just the same thing. Then once you move from the trachea to the bronchus, and then you go to the carina, you'll be able to reach the hilar structures. I've already explained this. These are potential places where nodes might collect. Okay, and they should be almost at the same level, or the right side should be just a little bit lower than the left side in most cases. If it is higher up, please look for pathology that is causing that hilar to be pulled up. Okay. Then that is the airway. So A, the trachea, the bronchus, and the hilar. You evaluate those things. When you go to B, look at what makes you to breathe, the lung itself. So how do you evaluate the lung? Divide the lung into 3 zones, each occupying 1/3 of the height of the lung. So you just draw imaginary lines there, 1, 2, 3. Okay, and then you just divide them, the upper third, the mid zone, and the lower third there. And then you start now moving side by side, comparing, inspecting each of the zones, comparing it with the contralateral side, and trying to see if there's any asymmetry. Once you look at the asymmetry, you now try to identify what is causing that asymmetry, and try to see the pattern of that asymmetry, and that moves you on to finding out what the diagnosis really is, or what is going on in that patient's lung. So apart from the zones themselves, of course, you now go to the pleura. The pleura usually is not visible in a normal X-ray, but now when we have things like pleural thickening, pleural effusions, the pleura now comes out. But in a normal chest X-ray, we're not supposed to. We cannot see the pleura itself unless, of course, it's diseased. Okay. Then the C stands for the circulation or the cardiac. So there we just assess the heart, which we already looked at. You just look at the cardiothoracic angle, and we've already talked about the fact that it should be 55% to 55%, but it only applies in a PHS radiograph. Don't use it in the AP radiograph. It will be quite misleading. Then when you're looking at the heart, inspect the borders of the heart. They should be very well defined in healthy individuals. Very important point. That gives you a clue of what is going on in the lung, which is adjacent to the heart. If there's any pathology going on, you find that the opacity, the distinction between the heart and the lung starts to phase out. So once you see that there's no clear distinction between the lung and the heart, just suspect something going on. And that is a good sign. It's called a silhouette sign, which all of us must be able to tell. Okay, so just examples of this, the enlarged heart there, you can see the heart is quite enlarged, filling up almost the entire thorax there. No need to even measure this. And on the right side, you can see that there is something going on there, which we'll discuss in the next slides. So the next, so we've talked about the A, which is the airway, where we talked about the trachea, the bronchi, and also the hilar. B, breathing, where we talked about the lungs and the pleura. C, we looked at the heart and the size and the borders. D is the diaphragm, where we now want to look at what is happening to this diaphragm, the hemidiaphragm. So the right hemidiaphragm in most cases is usually higher than the left because, as we all know, the liver is on that side. So it pushes that diaphragm a bit higher, okay? So on the left side, we are able to identify the diaphragm. We just look at the gastric bubble, and it will just be just above that gastric bubble. The diaphragm should be indistinguishable from the underlying liver in healthy individuals on the erect chest radiograph. So here we go. We have this right side. You can see that nicely dome-shaped right hemidiaphragm. On the left also, you can see that left hemidiaphragm. They are going to kiss the side of the spine. Good X-ray. Then when we look at the image on the right side there, you see the right hemidiaphragm there. But just under it, you see a radiolucent region there. This is air that has collected just under the diaphragm. This is a sign for perforated viscus. It could be anything that has caused air going into the abdomen. And you see that the air has collected up there, above there, just below the diaphragm. Of course, you can see the left side. It might be difficult to see because of that gastric bubble. But if pneumoperitoneum is extensive, you might be able to see both sides. Okay, then the costophrenic angles are also where these are just basically angles that are formed by the diaphragm, and they are supposed to be very sharp. When the diaphragm meets the borders of the chest wall, they are supposed to be this sharp. Okay, but if there is some fluid going on or pathology going on, As in this case, you can see there's haziness in that left hemidiaphragm there. Or in this case, where it's blunted there, you're not able to see. You can see the right side is very sharp, more like a beak of a chicken or of a bird. But this side is it's quite blunted. That suggests to you that there's something going on there. A collection there is happening. Then the E stands for everything else, though it is said everything else as a by the way, but really this is quite important. You don't, it involves a number of things that you really need to look at. The mediastinal contours, look at the mediastinum size itself, okay? It has potential spaces where a number of things can go wrong. Then also the aortic knuckle, you can actually diagnose an aneurysm just by the way the aortic knuckle is looking like. Aortopulmonary window, I explained this earlier on, and this is what I was just trying to say. The aortic knuckle is there, then that is what is known as aortopulmonary window. And also bonds. So some use B as bonds. In this one, I'm using B for breathing, but you find as you go through other sources, you find they'll use B and say bonds. It doesn't matter, just find what works for you and use it. So please inspect the bonds. If you're thinking of fractures, compare each rib one side to the other systematically. And of course, evaluate the soft tissues. You might just find a hematoma or a lipoma, something that can easily be missed if not looked for. And of course, if there are any tubes, lines, or what we call tubes and lines, look at them, see that they're in the proper area. They are not out of place. They're not dislodged. Make sure that you see those things. And of course, the artificial valves, pacemakers, and all those things, you need to be able to see. After you've done that, you need to go back to what are known as review areas. Personally, I consider these as the three areas. One, the lung apices, these lung apices. You need to go back because sometimes these areas can be overlooked. Then also look at the retrocardiac region. So this area that is behind the heart, because of the heart being there, it is easy to not take a second look. You just look at the heart and move on. But go back, you might just be able to see something behind the heart. It could be a lesion in the chest, but it's being hidden by the heart. But when you look closely, you'll actually be able to see it. Then also behind the diaphragm, remember the lung extends all the way down there. It doesn't stop here, but the lung extends all the way down there. So you might be able to see something, okay, behind the diaphragm there. And of course, the periphery of the lungs and hilar, which you should have ideally been able to see when you did a very nice ABCD. Okay, so this essentially is what I wanted to present to you on the chest radiograph. It's just a reminder. But then when you see something happening in the chest radiograph, you need to be able to now place it. You need to ask, what is it? And I've put it in an easy way, which I found. Firstly, when you see something in a chest radiograph, you've done, the inspiration is okay, the quality is good, and you see something wrong. The question is, what is wrong here? The only two answers. There are only two answers. One, either that area has increased density. Density is just basically we're just saying that it is white, or it has reduced density, which will mean it has become black. So that area is this area becoming whiter, or is it area becoming blacker? That is all you need to ask. So then when you say that it is whiter, you now divide those things. What pattern of whiteness am I seeing here? Is it a consolidation? Is it an interstitial pattern? Are there nodules or masses, or are there atelectasis? So broadly, these are the three things that you want to look at. Okay. Of course, there could be other things, but for our purpose, divide them into these four things. Am I dealing with the consolidation? Am I dealing with interstitial disease? Am I dealing with nodules? Am I dealing with the lung collapse, or what we call atelectasis? So quickly, we go through this in the next 10 minutes, how you look at these things, okay? So what is consolidation? So basically, consolidation is any pathological process that fills the alveoli with either these things, fluid, pus, blood, or cells in cases of cancer, that will give a consolidative picture. Okay, and this can be in a focal place or lobar, or it could be diffuse or multifocal. Okay, and sometimes you might just call them, they might be ill-defined opacities. Sometimes they can be well collected together and what we know as lobar consolidation. So pneumonia is by far the most common cause of the consolidation. It usually starts within the alveoli and then spreads from one alveoli to the other. And when it reaches the fissure, it then stops. The key findings in a consolidation as one, it will be an ill-defined homogeneous opacity, which will, one, obscure the vessels. So you look at the vessels, you find that the vessels will be obscured, okay? Then two, there will be that interface will be lost between the lung and soft tissue interface, it will be lost. Then also there will be these air bronchograms, so which we will demonstrate as we go along. So you need to see, when you see these air bronchograms, these ill-defined opacities, okay? And then it will extend to the pleural fissure, but not cross it. And then lastly, if you don't see any volume loss, then you can call that as a consolidation. If you see volume loss, think of something else. Could be consolidation collapse, okay, or just basically collapse. But try to figure out, am I dealing with a consolidation proper, or it could be a collapse? So that is how you would define a consolidation. And these are the things that will cause consolidation. And of course, TB is right on top there. Lung cancer is so much. These slides will be shared with you. You can look at this loaded, and for those who are very academic, you can go through these things and then and see how that pattern goes through it. Okay. And so this is just trying to demonstrate the lobar consolidation here. And sometimes it can be diffuse. You can see that it's not really in one area, it's diffuse. Okay, in the right, mid, and lower zone here it's almost the entire left lung is taken up. Then it could be multifocal, where we have these patches. Here we can see the area of ill-defined opacities there. Here also some area of ill-defined, and a bit there in the lower zone there. I hope, are you able to see they're able to see this? Yeah. Okay. So then this is just trying to demonstrate an area of lobar pneumonia. And as you can see, if you with an eye of faith, just look at this area, it is white. And within this whiteness, you'll be able to see some linear blackness, okay, which are going through. Those are what we're calling the air bronchograms. Okay, so that we call it the proper consolidation. Okay, so these are just examples of things that can cause a consolidation. In this case, just a lobar pneumonia. And in this number 2 here was just a patient who had a lung mass, and then the patient had a biopsy, and then it bled, and you can see that now there is a mass there, but then there is this surrounding region which is now blood that has collected because of the bleeding that happened after that needle was placed in there. Okay, so there are other things that can cause consolidation, which you can look through in this slide. Okay, then apart from the alveoli being affected, we can have these supporting tissues of the lung, okay, that can be diseased. These can now present as an interstitial pattern, okay, and these result in fine or the coarse reticular opacities, or indeed small nodules. And TB comes right in here as well. So this is how a refined reticular interstitial pattern will look like. Okay, so you can just see this haziness. Okay, and then also a coarse, when they become much more coarse. Okay, they will be reticular. You won't be able to see them. You should be able to differentiate this from air space or alveoli, or those that are affecting the alveoli. Okay, and of course this comes with a bit of experience. As you see the most of these X-rays, you'll be able to tell the pattern. And of course, you can have these fine nodular. Sometimes they call them reticular nodular opacities. So there will be small nodules, but they will be in this linear form. So they will have this interstitial pattern, kind of, not really a consolidative pattern, but this reticular pattern and typical really of things such as TB. Okay, so these are just examples of what can cause a reticular pattern. And on an X-ray, even cystic disease can cause an interstitial pattern. It's only when we do a CT scan that we will be able to differentiate sometimes that cystic disease proper from an interstitial pattern. So you can see on an X-ray, we can call this as just an interstitial pattern in the lower zones. But when we did a CT scan, you can see this cystic. The CT just brings out this is much better. What is known as a UIP pattern. Okay. So the other thing which we need to look at, we looked at if it's white, it can be consolidation, it can be interstitial pattern. The third one is either a nodule or mass, and this is quite easy. Any space occupying lesion can be either solitary or a multiple. It is called either a mass or indeed a nodule, and that is depending on the size. So a nodule, basically, a nodule is something that is less than 3 centimeters. Anything above 3 centimeters and above, we call it a mass. And of course, you can divide those nodules into micro nodules, or meter nodules, and et cetera, et cetera. But generally, anything above 3 centimeters is a mass. Lower than 3 centimeters becomes a nodule. And these are just examples of some of these nodules that one can see. Then atelectasis is basically a collapse of a part of a lung due to a decrease in amount of air in the alveoli, and this results in volume loss and increased density, and it can affect any of these lobes. Okay, so and the causes of atelectasis can be either resorption or relaxation, where you can have something right inside the bronchi, or it could be mucus plugging, it could be a tumor, it could be a foreign body, or indeed it could be something that is outside, like a large pleural effusion, which causes a compressive atelectasis, or pneumothorax, or a rounded atelectasis. So these are some of the things that can cause an atelectasis. So how would you tell that a particular lobe is collapsed? And I just spent time on this because sometimes you might see something in a patient who you're thinking is TB, and you call TB, but you need to be able to differentiate that particular pattern from TB proper. You could just be dealing with an atelectasis instead of a proper TB infection or something else. All right, so right upper lobe atelectasis, how does it appear? It will be like a triangular density. Okay, so these are some of the 3 things you look for: triangular density, the right hilar will be elevated, and also when you do a lateral X-ray, you'll be able to see that the retrosternal space is obliterated. It's not there anymore. Okay, so then these are just again, you can see that this is a triangular feature of right lobe atelectasis. Then the middle lobe atelectasis, basically look at the right heart border. If you see the right heart border is not well defined, and it's hazy, you can't actually see it. Like, remember I told you the border should be as sharp, but when you look on the right side here, you're not able to see it as sharp as this side. It's obliterated. And when you look at it, when you do a chest X-ray, it just gives it away. There's that triangular shaped region there, which is slam dunk for right lobe atelectasis. Then the right lower lobe atelectasis, there the sign, what you just need to look at is the pulmonary vessel there. If the right lobe is collapsed, this vessel is taken up as can be described here. You can see that that lobe, that vessel is not seen, and that sharpness is gone. All right. So these are these signs that one can be able to tell, and I will share the slides. Please go through them nicely. Then the left upper lobe also, when there's left upper lobe atelectasis, please look at the heart shadow. You'll find that the heart shadow will become hazy. There will be the band of increased density in the retrosternal space, but the aorta and the aorta and the descending, I mean the aorta, the aortic knuckle and the descending thoracic aorta edges will be quite evident there. And when you see that, please, and of course, when you see also there is a reduced size, volume on that side, you call it atelectasis. Just look carefully. And you differentiate it from the left lower lobe atelectasis by the fact that one, on the left lower lobe, they'll be reduced, the hemidiaphragm on the left will be completely gone. Apart from the fact that there will be reduced size of the lung, the left hemidiaphragm will be lost. That shows to you that there is left lobe atelectasis. So sometimes you can also have a atelectasis of an entire lung, and that what is known as a whiteout or entire hemidiaphragm looking white, just because of atelectasis. So how do you differentiate this from a pleural effusion? Just simply look at the heart. If the heart has been pushed, okay, then that's a pleural effusion. But if the heart has been put towards that area of whiteness, that shows to you that there is actually an atelectasis there. So this is just a summary slide that's trying to show you the types of atelectasis there, which one can look at. All right, so sometimes you cannot be able to tell a particular pattern, right? But one needs to always look at these differentials and try to get the overwhelming pattern and try to work from that, try it with the clinical data that is available, and if there are previous images and all that, you compare, and then you, of course, go for it. But in some cases, you might not be able to get it, and of course, definitely diagnosis will come, other things like biopsies and other blood tests that can be done. Okay, so the other part, so we looked at the part where it's white. Now for the lucent area, basically you look at three things. Am I dealing with the area that is there a cavity or is there a cyst? Okay, and how you differentiate it just by the wall. So if you look at an X-ray and the problem there is that this area is lucent or it's more black, you look at the wall of that area which is more black. Is the wall thin? Then you call it a cyst. If the wall is very thick, you call it a cavity. And of course, other things can come through, but for a purpose, we can move there. So then, so this is just an example of a cavity. You can see that the cavity will come out from a consolidated area, and it's the area of consolidation. But then this area of lucence there is a cavity there. Okay. Okay. So these are just examples of the cavitatory lesions which come out of the consolidation. Okay. All right. So this summarizes now the key the points for interaction today. Number one, please look at the technical quality of an X-ray. It's everything. Number two, you just be systematic when you're reading and develop your own system. Don't be too dogmatic about it, and just be systematic and be consistent. And also identify the overwhelming pattern of disease when you see a problem there. Is it a radioopaque? And you divide them into wells for, or is it a radiolucent? And try to work it down. Is it a cyst or is it a cavity that I'm dealing? So with that, I would like to end here and pause for a few questions. I've got a few, we just want to interact with us. I've got a few slides here. I don't know whether maybe we should ask a few questions.
Right.
Or
right. Thank you so much, Dr. Nteeni, and definitely you will agree with me that it was a very, very loaded presentation. We have covered quite a lot, actually. This is content for a week-long workshop on radiological diagnosis of TB. So I actually applaud you all for having listened in. I was just checking on the participant list. We hit close to 670 people joining the call, which is quite impressive. Now, colleagues, if you have any questions or things that you'd like to clarify based on the presentation, please do signal to us by raising your hand or put it in the chat box. Are there any comments or questions regarding the presentation? Okay. Right. There's a hand from Niza Sinkonde. Niza, please go ahead and unmute. Give us your question or comment. All right. Maybe you are struggling to unmute. Just give it a second. Please try to unmute.
Thank you, Dr. Singini and Dr. Nteeni. It's a well elaborate presentation. As Dr. Singini has mentioned, it's loaded, so we may need to go through it again. I have a comment and also a question. Currently, we have very few X-ray viewing boxes in facilities. That's across Lusaka, and some are not even being used because we are receiving just digital X-rays, especially chest X-rays. When you send a client to these general hospitals, they are actually capturing with the phone, because this question was also raised last week during advanced HIV disease meeting at Kanyama General. So do we have any solution to that in terms of how they can just send the clear images to the clinicians, or maybe ways of printing them, maybe on saving them on discs, so that maybe the clients can come with those and then review them in real time, because they're not even being saved from the X-ray machine where they are being captured because of mentioning of space and saver. Thank you, Doc.
Right. Thanks, Dr. Sinkonde. Any other comments or questions regarding that? So maybe I could actually ask Dr. Chitalu to respond to that question in part, or Dr. Mputu, since you're from the program. In fact, let me ask Dr. Mputu your comment on or reaction to Dr. Sinkonde's point. All right. Maybe Dr. Mputu is struggling to unmute, but in response to your question, Dr. Sinkonde, that is more of an administrative issue. So hospitals should be at liberty to explore ways that would work best for you. But however, some things can be done differently. Where your hospital can manage to put it on a disk, that's fine. And also for the digital X-rays, actually, there are some special films that can be inserted into a standard printer, and you could print it just the same way you print on a plain paper. So that's something that can be explored. But if you want to maintain using digital platforms like WhatsApp, so the person handling the X-ray machine or the radiographer can actually get a screenshot of the computer, other than getting a phone camera and taking a picture of the screen. You can get a screenshot or use a snipping tool on most Windows computers that is available. You'll get a better resolution of the picture, which can be sent to the clinician via whatever platform, WhatsApp, email, etc. That can be used. So I hope that helps, Doc.
Just to add on that, I think we should also move towards the fact that we need to move packs, whereby right now even doctors or clinicians are able to receive images on their phones. Okay, when we connect ourselves, so you can just go online, you just put yourself your details, you sort of get the information there, and from there you can even adjust the contrast. You can adjust it in a way that's because what I've seen sometimes, radiographers might be able to get images, but maybe they play around with the contrast, and sometimes you find that maybe a radiographer or a technologist there is not so conversant and so hasn't done a good contrast, and you find that the image doesn't come out well. But if everyone is connected and you are able to access it online, it makes work quite easy, and that is what we should be talking about, connecting everyone online and accessing these things online.
Right. Thank you, Dr. Nteeni. So I've seen there are a few comments in the chat box, most of which are requesting for the slides to be shared. But there's an interesting question from Christabel and Silvana from the Copper Belt, who are asking.
Don't just confuse them. Okay, don't know their stuff.
Right. So please keep your mic muted. Right. I was saying there's a question from Silvana and Christabel from the Copper Belt who are asking, how do you differentiate fibrosis from active TB? So that's a very, very good question. So before I ask the experts to answer, there's a hand from Kelvin Chishala from CDHO. Please go ahead and unmute and ask the question, Kelvin.
Thank you very much. Good afternoon, Doc. Hope I'm audible.
Yes, you are.
Thank you. So mine is a request, Doc, not necessarily a question. I think I appreciate the presentation, and this is something which we really need on the ground to the staff who are actually seeing our clients, and this will be very helpful to actually improve on the diagnosis of TB using the X-ray and the interpretation of the X-ray. I think like the doc previously said, the one who spoke earlier, I'm trying to ride on that to ask if it is possible that there you've given us this overview of what is expected or what we can look at. Is it possible, Doc, that you can break these presentations into certain categories where if you are to tackle, maybe let's say you want to teach us on how to know that this is a cavity here, you bring it out in so much details that we understand the point where if a staff is working in ART, orders an X-ray, they are able to do that if there is no doc or medical officer to consult from, so that they're able to help this client and without missing the diagnosis. Actually, this is very helpful, just that it is too much. It is very much loaded, Doc. Thank you very much.
Right. Thank you so much, Kelvin. And your concern is well noted. And as we make the curriculum for ECHO next year, we will definitely put it into consideration. Maybe allow me to also take advantage of this point to mention that we are considering to actually have a second session on radiological diagnosis of TB on, using chest X-ray. Tentatively, we will announce through the usual platforms, but tentatively next week, Thursday, between 12 and 13, we are hoping to have that hour to discuss part 2 of this session, where we will dive deeper into pattern recognition associated to tuberculosis on chest X-ray. So I hope, Kelvin and your team, you will be able to join in that call. But also to respond to your initial request to break it down to smaller ones, that is work in progress. And we will have more of such trainings, both in-person conversations, as well as virtual trainings like the one we've had today. So there was a question initially about the difference between fibrosis and active TB, how you make the distinction on chest X-ray. So before I ask Dr. Chitalu Chanda to respond to that question, Dr. Ngoy, you have your hand up.
Yeah, thank you so much, Dr. Singini. It was a really brilliant presentation, and I've noticed that everyone really liked it. I wanted to ask to the presenter if you can make a brief comment on the use of CAD, computer-aided diagnostic, especially the ones that is mostly used in the mobile trucks. because we noted that most people are initiated on TB whilst the mobile track is being used, and they follow the images that come, which is color coded, and based on the colors, and they make instant decision to say this is TB and so on. So I wanted the presenter to make a brief comment on that, so that it could be maybe help us to maybe avoid putting wrongly people on TB. Over. Thank you.
Brilliant question, Dr. Ngoe. So let's ask Dr. Chanda Chitalu if you could respond to the major differences between fibrosis and active TB. Then also ask Dr. Nteeni to respond to the last question. Right, so while we are waiting for Dr. Chanda, maybe Dr. Nteeni can respond to both questions if he would like.
Okay, so for the differences between fibrosis and active TB, so I'll avoid answering that question because to be nicely done next week, that will be it. That will be the essence for next week's lecture. So here we're just looking at the patterns. Of course, I talked about most of the patterns which are also TB related, but next week we'll delve in specifically primary TB, secondary TB. What are those things that we can see in primary TB versus those in secondary TB? Then from there, we'll look at what changes, what are the complications of TB post-treatment changes, and that will come in with fibrosis, all those things. And then how do we differentiate between the fibrotic gland versus active TB on X-ray, if at all there is a way that we will be able to do that. So that will actually be the essence for next week's lecture. So just hold your guns. We'll be able to sort it out next week. Then concerning CAD, yes, CAD has seen, there have been various studies that have shown CAD to be quite useful. We participated in that. And on the clinical aspect, I think there's definitely something we need to improve on. Of course, something newish somehow, but we'll keep on improving these AI issues. And in the coming few years, I'm sure it will be very helpful for all of us. It shouldn't be seen as something that is taking away our jobs or anything like that, but it should be something that will complement the work. And especially for us who have this other information, when we still see that there's something wrong there. Sometimes you find CAD who call fibrosis as active, but you who has this other information, you'll be able to tie it with the clinical aspects and that the human part of us, the human medical part of us should kick in, and we shouldn't simply be computers and following what CAD is saying. We should put it in its right place. It is there to help us manage these patients, but it should not make us stop to think and to reason and to tie with the clinical pictures that these patients come with us. Especially previous images, previous treatments, all those things. We are now supposed to relate it with CAD and ultimately help the patient holistically.
Right, thanks. And I see Dr. Muyoyeta has raised her hand. Dr. Muyoyeta, please go ahead with your comment.
Hi, please confirm you can hear me.
Yes, we can, thanks.
Yeah, so I wasn't able to unmute. I just wanted to add to the question on CAD. Just to add to what Dr. Nteeni said, I think when you look at the CAD, and I know the one you're referring to on most of the tracks is the CAD for TB, it simply gives a score of 0 to 100. And so the caution is that score, first of all, is not a diagnostic score. It really is just giving you a likelihood of TB. Any patient with a high score of CAD should undergo, sputum testing, and a clinician should review that X-ray. So really the caution is that a high CAD score is not equal to TB diagnosis. And yes, we have noted that whenever the X-ray, mobile X-ray units are out, they have noted an extremely high number of clinically diagnosed TB, which is concerning. My request to the conveners for ECHO and to Dr. Nteeni is that we should have a session on CAD, an additional session on CAD in addition to your session. And we do have a set of slides that were developed for this purpose, which I could share. Thank you.
So much, Dr. Muyoyeta. Thank you.
Right. Thank you, Dr. Muyoyeta, for the comment and adding more to the conversation on CAD. Are there any other questions, comments, or contributions on the presentation? There's a very interesting question in the chat box. Let me just quickly get to that, where Duana Piri was asking what period of time does it require for someone who had an abnormal X-ray and completed TB treatment for it to resolve and get back to normal? So that's a very, very interesting question, which we are going to discuss a bit more when we meet in the next session on Thursday next week at 12 hours. There's also a question from a comment from Simuto, who's asking that I would like to know how to differentiate hilar lymphadenopathy in a normal X-ray. Yeah, or rather differentiate hilar lymphadenopathy, or rather pick up hilar lymphadenopathy on a chest X-ray. So that's actually a very, very good question as well. And so we will discuss a bit more about the characteristic patterns you find in TB. You know, I've seen a number of us, me inclusive, when I'm seeing patients where I've interpreted a lot of chest X-rays saying there is hilar lymphadenopathy primarily in the right lung field, extending from the hilum all the way to the right lower zone. And, you know, when I interacted with people like Dr. Nteeni, they told me those were blood vessels and the branches of the right main bronchi. I was shocked. So, you know, this presentation comes at the right time when we are concerned about the number of clinically diagnosed TB patients who may not actually be TB. So with that said, are there any questions before I allow Dr. Nteeni to take us through the last few slides, which are just showing a few pattern or textural changes on X-rays, just to highlight some of the points he talked about, and also take advantage of that for him to give us his concluding remarks. But before I do that, Dr. Mputu and Dr. Chanda, any additional remarks on the presentation and the conversation so far? Let's start with Dr. Chanda.
Dr. Singini, just verify that you can hear me.
Yes, we can.
Okay, so firstly, great presentation, Dr. Nteeni. And I think you had a very good attendance. And so just to add further on, I think it's very important that when you are looking at X-rays for your patients, you really want to ask yourself if things were done in order. You identify the correct X-ray. You don't want to give a pathology to a patient that is not there. And when you look at the X-ray, I think it's always important to ask yourself, is it actually there? Is the disease actually there or not? And I like that Dr. Nteeni has given us different pathologies that we can appreciate in TB. And we'll see that some of the patients later on might have just a normal X-ray when you look at it, and that will not mean that there is no TB. So in addition, I think that on the card, like Dr. Muyoyeta has also said, I just want to echo that probably it's something that is useful where you don't have Dr. Nteeni, and some of you might not have access to Dr. Nteeni. It really will help you. You're just seeing this X-ray and you're totally confused. The card will give you some help. but it's not superior, Dr. Nteeni. Just remind. Sorry about that. So I think that I look forward to the next session where we'll look at TB and X-rays. And I've seen some patients have been studied on TB based on X-ray 5 times, 7 times. So next week will be interesting on Thursday, and I just urge everyone to join. Thank you.
Thanks so much, Dr. Chanda, for that. Dr. Mputu, any comments also from the program side, regarding partly what Dr. Sinkonde alluded to regarding the view boxes and, the quality of the images that have been circulated following digital imaging for X-ray? Any comment? Sorry to put you on the spot to represent the program. Yeah. Right. We are struggling to get Dr. Mputu to unmute. But in the meantime, Dr. Nteeni, please, let's wrap it up with the last set.
Okay. All right. So just want some feedback on this X-ray. I'll just flash a few X-rays. Just tell me whether this is a good X-ray or a bad X-ray, and tell me why you think that is so. So just unmute yourself. Just tell me. So I'm sure everyone is saying, is this a good X-ray or a bad X-ray? Anyone, please.
You can even put your responses in the chat box.
To be faster to unmute, no? I think just unmute.
This is a bad X-ray, Dr. Nteeni, because underpenetrated.
Fantastic. Why are you saying underpenetrated? Give me 3 reasons.
Because the cardiac silhouette looks completely white and we can't appreciate the other margins of the anatomy of the chest.
Fantastic. So the cardiac is very bright, and just behind the cardiac there, you're supposed to see these vessels down there. So we can't see that. And also left hemidiaphragm, when you follow the left hemidiaphragm, it stops somewhere there. You should see it all the way kissing the spine there, and you can't even see the vertebral bodies. Those 3 things: vertebral body, the cardiac shadow, left hemidiaphragm, should always. That's a great answer. Then yes. How about this one? Should I put you on the spot and speak for everyone because of time? How is this?
It's overpenetrated.
What's that?
I think it's overpenetrated. The lung fields look unusually dark with no vascular markings, and you can't appreciate any other structures in there.
Say no more, say no more. Next. How's this? How about this one? Okay, there's a pathology here. Let's assume that everything is penetration, everything was okay. But can you spot out the pathology that is here? Anyone? Let me not put you on the spot, but anyone, if you've seen something, just unmute yourself, please, and tell me. We don't have time in the next 2 minutes.
Looks like with the lobar pathology, we'd say middle zone.
Middle zone. Okay, try again.
It's a consolidation.
No, not a consolidation. This one, if you miss it, you are repeated 20 times.
The lung collapse.
Lung collapse on the right.
Lung collapse, great. There is lung collapse. Which side, left or right?
Right.
On the right. What else? What is causing the lung collapse? That is not enough. You need to give me the definitive reason why there's the collapse. Something that will kill the patient, no? Say it.
Pneumothorax.
Absolutely. There's a pneumothorax. You just follow. So there's a long lung, and there is just air. Oh, this is air that has collected. Okay, so this you don't want to miss, especially in the ER. That can save somebody's life. Then and somebody was asking about hilar nodes. Those are the nodes that you see there. How about this one? Can somebody tell me what this is? What pattern is this? The pattern, we're looking at those patterns which we are talking about. What pattern is this?
Overexposure or miliary TB.
Okay, great stuff. So micronodules, yeah? And full stop. This one?
There's a pleural effusion on.
This is over or under exposure? Did you say overexposure?
No, this is under exposure or diffuse reticulonodular appearance, like a miliary picture, sort of.
Yeah, so not overexposure per se, right? Maybe, but yes, miliary picture. Then this one, you can continue, please.
There's a pleural effusion. I can't see the sides being labeled, but I think it's the.
Fantastic. This one. What pattern? Just need the pattern. The pattern. What's the pattern is? What pattern is there?
It's like a calculation.
Palpitation in the left
Looks like
upper lobe.
Of it in the upper left zone.
Okay, so left upper zone, you can see there's an area of consolidation, isn't it? Are you able to appreciate the air bronchograms? You've seen these lines, eh? Okay, so this is a consolidation, but within that consolidation, are you able to see this in the middle? What is that called? That's a cavity, no?
A gun focus.
So that there's a cavity. So there's a cavity, there's a consolidation, and then within it, we see that cavity there. Cavity, yes. And then this. Same thing, right? You can see there's this cavity here. When you put it on the lateral, it comes out. I hope you're all seeing that. Same thing, cavity there. Okay, I think those are the two the cases I wanted us to see. But I thank you so much for your attention, and looking forward to next week when we look at TB proper. Oh, there was one more. What is this one? This one, I'll give you 100 kwacha, whoever gets it. And I'm serious. Anyone?
Upper lobe lung collapse. Yeah, Robert said first.
Upper lobe lung collapse.
Oh, there's a lung collapse.
Lung
On the
collapse,
right.
what's the pattern? The question is, what's the pattern?
Triangle.
Yeah,
Right.
My number is 09.
Right. So since a lot of people shouted the correct answer at the same time, it's hard to pick out the person who said it. Otherwise, well done to everyone, and it's really been a great session. These slides will be shared, and the reminder is that you register your participation using the iEcho. This is a link that we circulated in the WhatsApp platforms, etc., so that you will be getting notifications from our end informing you of the echo sessions that we're having. And it's through the same platform that you will be able to receive a certificate for attending today's echo session. Otherwise, it's been a very, very good session. And, I'm very glad to see people sitting in congregate settings like at Chilubi Island. That is awesome. I can also see Ndola College of Nursing. That is remarkable. Mansa School of Nursing, we see you. Well done. I hope you found this beneficial. Mr. Mvula from Monde, I see you. It's great that you joined us, and we hope that this session was very informative and will help you improve the quality of the care for TB patients in the country. With that said, allow me to thank all the subject matter experts, Dr. Nteeni, Dr. Chitalu Chanda, Dr. Mputu, Dr. Muyoyeta, and the entire coordination team from the ECHO hub here in Lusaka, Tambuyu, Kote. Well done to the team. Looking forward to meeting you next week on Thursday at 12 hours for part 2. we are signing out. This has been your host, David Singini. Bye.